Thank you, Valentina, and thank you to all our organizers, the association, to our patients, families, caregivers, and our sponsors for the meeting. It's wonderful to see so many people here. The Patient Registry for Wilson disease, to which we refer to, I will show in a few minutes, the number of the people that have been involved with it, but the association has been pivotal in understanding and being very generous in supporting this registry. And I'll try to give you examples of why we have a registry, what it is, what it can do. And I think to Valentina's point about this being sort of the future therapy, you have to know where you've been and how good things have been or not good to really know where you're going to go in the future. And that's what registries really can provide. So what is a registry and what is a biorepository that may come along with a registry? It really is a collection of information on patients that's kept in a very carefully protected manner so that the data is, the names are not exposed, but they become very important information that allows us to ask questions and then to answer these questions. The biorepository is a collection of specimens that come from the patients that can be utilized also to answer other questions that arise. So let me give you very few, very simple kind of things we can ask. Are there equal numbers of men and women with Wilson disease, as it should be from the genetics of the disorder? What symptoms do patients have at the time of their presentation or at time of diagnosis? I'll show you a tiny bit about that. And I think there was a wonderful question that came up during the question and answer last session. There was somebody who asked, if I have a hepatic, do I go on to get neurologic? Or do I flip-flop back and forth? These are the kind of things that you can answer when you have not just a one-time, or what we call a cross-section, but a longitudinal, a follow-up of patients who've been in a registry that are looked at over a period of time. And then other simple questions like, what medications do most patients use for Wilson disease? And again, that may be dependent upon where the patients for your registry are recruited from, because these are not like the compilation of information that comes from all of prescriptions and all use throughout the country. Now, you can also start to really talk about very detailed questions as well as the simple ones. How do we define successful treatment that goes well beyond survival? And then what are the parameters we look for to say that the liver is doing well, the central nervous system is doing well, that people have good mental health? And then what defines stability for the patients from their perspective and also from the treaters? And what should we be looking for as we approach all these new therapies? And I think these are the value. When you can start to begin to answer these questions, that's a great value to the community for the purpose of moving the field forward. So the aims of our registry that we have is really to define the natural history. Now, the natural history of disease is sort of in two parts. One is the disease itself at presentation, which includes a prehistory because patients are born with Wilson disease, but they're not always diagnosed for many years. And then the second part is the natural history on treatment, which says, how do they do once we start therapy? And then the other things that we can do is look at what are some of the variations in the disease. Are they changing over time? And then we can always look for, in our evaluation, how do we look at ways of defining how patients are doing better? So we can look at neurologic scoring systems. We can look at parameters of mental health, of what we call cognition, the higher functions to do very detailed tasks, as well as looking at non-invasive ways to say how well is the liver doing and how much fat may be in the liver without having to do very detailed testing. These are all the things that we can start to approach. Other things that we're doing in tandem using some of the specimens are doing collaborative work to really find best ways of measuring bioavailable copper. And the work that we've done from the registry has led to other development of assays that have been used in other trials and have become standards for the use in future clinical trials as well. So these are our study sites. We've had patients see us in Yale, in Baylor, in Heidelberg, Germany, in Surrey in the UK, in Seattle Children's Hospital, Advent in Florida, Aarhus in Denmark. Wake Forest has also joined us. And we also, although not a formal member of the registry site in the sense of data exchange, we also pool data with our colleague Zoe Mourinho and the Spanish registry, which has a large registry throughout the country of Spain. So what are some of the things we do to, we were interested as we set this up, not in just collecting the most numbers, because there's ones from Poland, there's ones from Germany that have hundreds or thousands of patients over 20 years already, but getting very detailed information that was not prospectively collected in a very formal manner to be able to assess all three different dimensions of the disease. And so when we set that up, this was our aim. And this is why we have people come to the centers for the initial evaluations, because we need the hepatologists, we need the neurologists, we need the mental health professionals to work with us to be able to then capture these elements very accurately. We have the data capture from the laboratory testing, the urine testing, and then we also have other collections of these specimens that are stored. We have looked at again, as I mentioned, that bioavailable copper. We've worked initially with Seattle, now with Aarhus University, to do sequencing of the DNA for confirmation of diagnosis, as well as in the future being able to look and see, do we have very unique patterns that may appear. We've collaborated with Professor Si-Hoon Han in Seattle in developing the peptide assay, which is an adjunctive test in terms of diagnosis, which is being explored now for potential use in population screening, as well as collaborated with Professor Wooten out in Houston, who's been looking at bile acid parameters and the different composition of that in pediatric patients. So we've been able to do a good deal. Now, as I mentioned, we have that multidimensional assessment, the liver, neurology, and psychiatric, and includes various different what we call instruments or things that have been validated for use for assessing a certain parameter. And we do all these collection, and all that data is recorded and kept within the database. Now, within our site, we have the people that represent all these different dimensions. You can see we've got coordinators as well as data people, pediatric, adult neurology, pediatric neurology, psychiatry, psychology, research administrator, as well as helps us actually keep this functional, as well as biostatisticians who help us in terms of both understanding what we want to collect and then taking it and trying to analyze it in a very careful way. So these are some of our team members, for people who've come out might have met them. It took 3 people to replace Aisha, and so on the left is Hatice, in the middle is Sefa, and on the right is Asim, and you may have met some of them along the way if you've joined us. We started the study at the very end of 2017, and we have the vision over time to do a very intensive analysis for the first 5 years. Why 5? Because we actually found that there was a lot of stability in most patients by the time we were reaching 5 years. And then for those who do not achieve that stability, we continue the more intensive assessment. And for those who have achieved that stability, we do sort of a modified evaluation that is sort of a little bit registry light and less direct time spent with the different professionals, but using certain instruments that'll help us detect if there are changes. And then we can always put somebody back into the formal, more detailed one should they change. So this allows us to capture how well people are doing, what the parameters are during the course of therapy. Now I'll show you a little bit of some of the data we have. All right, so this has sort of just been our enrollment in general, and you can see the line, the big line in the middle just keeps going up, and that's the total participants. The line next to it, a little bit under that, is the line of the adults only. And I happen to say that we currently have about 60 pediatric patients, which for a cohort with Wilson disease is very significant. And we also have a number of the pediatric patients who started as pediatric who've graduated into the adult part of the study as well. Now, in terms of people staying with us, it's really been incredible. The vast majority of people have stayed on. We've had a few people transplanted, and we've had a couple of deaths that occurred during the early COVID period because we started during that time. But the majority of people we have had multiple data points on, which allows us to start doing a lot of different review of the data and try to draw different conclusions. So just to give you a few ideas of kind of some of the things we have, the simple things first. So most of the people have joined us have been about, on average, about 30 years of age, but the majority of people were diagnosed, at a mean of somewhere about 18 years old. But this is, again, it's a little bimodal because we do have, this is all the patients, not just breaking down the pediatric from the adult. We have, again, going back to that simple question, how many males, how many females do we have? And the answer is almost equal amounts, as we would expect for this disease. Now, there was a great question about the symptoms in patients, and some of our previous speakers spoke to the change that may occur in patients during the time of after the actual disease manifests till the time they're actually diagnosed. And you can see that there are differences from the time of presentation to diagnosis, including a higher percent of patients who may not have had as much overlap of the mental health to the neurologic side. So these are important things to look at, and then we can follow this over time. I'm going to go very tiny, just mention a tiny thing in this, so we're able to look at liver function, and then look at it in the beginning, look at it at the end of the study. The means don't change very much because the majority of our patients have been on treatment for a period of time. So that speaks to the stability of the disease if people are well treated. But we do have subsets of people who were treated for less time, and those individuals we tend to see more of the changes, hopefully more in the positive for various different aspects. We've been looking at the neurologic scoring, and pleased to say the averages, if you look at the beginning, at the time of enrollment till the time later on, have improved. But again, these are things that we can look at in subset as well. Those who present with more significant symptoms at the outset, with treatment, we see a much more change than if we look at just the population as a large. We will be sharing at the upcoming American Association Study of Liver Disease meeting an analysis of what we call the MoCA score, or estimates of cognitive function. I'm pleased to say the vast majority of patients have normal scoring on this instrument, which is scored from 0 to 30, and if they're above 26, that means they fall in the category of normal. And we've been looking at, over time, different categories of patients, the phenotype, and how do they do in terms of responsive therapy. And there have been some interesting findings, and we've been able to correlate this as well, given that cognitive function is, again, a brain function, and looking at also neurologic disease in those same patients using some of the other neurologic rating scales. And that's some of the data that we will share at this meeting. And there are some interesting correlations. Now, if we look at treatment duration, we do have a population that we're very interested in. Again, is the patients who are under a year of treatment. Not that every patient isn't interesting. We gain a lot of information from all patients, but it's important to look at the patients at the beginning. We also have the ability to look at changes in the use of medications. So you can see a smattering of all the medicines in the adults in the beginning, and then even 4 years later. And interestingly, in the pediatrics, there was sort of a diminution of use of penicillamine over the course of time in the study. Now, I'm going to stop here. I just really want to say a great heartfelt thanks to the association. Mary Graper before, now Rachel Albert, who's been our liaison. So within all the investigators, when we meet, we also meet with the representative from the association because we feel that it's important they understand and actually contribute to asking the important questions so that we can continue to modify and design to be able to pick up changes that are very important. Special mention to Zoe Mourinho. Zoe spent last year with me at Yale and is back in Barcelona and doing work again on the National Registry there and collaborating with both Thomas and ourselves and the whole group. And we have another 2 posters, one last year that was on fibrosis, non-invasive markers, and now on steatosis as well. Chris Harrington, we've worked with. He's one of the leaders in the world in measuring copper, and he's at the laboratories up in the UK at Surrey. And to a real, very special thank you to all of you who've taken the time to join us. There are a few here today, and it's really very special, and thank you for reintroducing yourself if I haven't caught you just directly. For people who have joined us. And just a few pictures from over the years of some of the people that we've worked with. We had actually, the genesis of the study came about and through a couple of very nice people. Michelle Camarado, who sits in the upright corner all the way to the right, was a fellow at the time working with Aftab Allah, spent 2 years with us and helped us really establish all the rudiments that allowed us to get the registry going. And then there's a large number of people who are here in various different parts of the world that have been very integral to us being successful for this. So thank you very much, and we're happy to take questions when it comes to the time with the group.